Our next presenter, Dr. Goodenowe, he's on to something that's really cool, awesome for brain support. He's going to talk a little bit about plasmalogens and how important these are to cellular structure. So, Dr. Goodenowe.
Thank you, Sean. Excellent. So Sean's definitely putting us through the motions of rapid talk conversation here. So thank you for the opportunity to be in this really esteemed group of people. And as you see, Dr. Jordan, Dr. Hazan, we all do a whole bunch of different things. And so we had, challenging aspect is to pick one thing of interest for people to talk about. So I'm going to talk about multiple sclerosis and a little bit about ALS. And I'm kind of going to do a deep dive in one particular patient, but give you a bit of an understanding of the overall system. But we're really talking about not delaying dysfunction and death in these neurological disorders. We're actually talking about stopping disease progression and initiating restorative neurology. And I really want to add to Dr. Jordan is that the brain is not a bowl of soup. And what we're seeing in this conference is how regenerative the human system is if we give it the tools it needs to regenerate. So this is an individual with multiple sclerosis, primary progressive multiple sclerosis, just 5 weeks ago. And he basically has very limited mobility, very limited strength, almost negligible use of his legs. He's virtually immobile in many ways, can't get himself off the toilet into his wheelchair, so to speak. And that's where he was 5 weeks ago. And then where he is today is here, and so this concept of being able to provide strength and mobility and the regenerative capabilities of the human body are quite dramatic. And so our objective with him is to get him climbing stairs, hopefully by the time he leaves the facility in 2 more months. But what I want to talk about is a case study with Lisa. And so here's a woman with multiple sclerosis diagnosed with optic neuritis when she was in his early 20s. So she's 53, 54 now. And so she's been legally blind for 30 years. And so we started her on a restorative neurology process of plasmalogen restoration of the membranes of the brain, antioxidant, some mitochondrial support supplementation. And surprisingly, in about 6 months or 7 months after therapy, she starts being able to see out of her blind eye. And so she can now read. So the interesting thing is, how does someone who's been legally blind for 30 years restore vision? And how do we actually monitor and track that? And so we're talking about defeating multiple sclerosis. I'm going to go fast because of time here, but the cellular and biochemical mechanisms of MS, how to restore cellular and biochemical function, and then ultimately I want to spend more time talking about the tracking, because if we're seeing these physiological changes in the individual, then we have to be able to see objective measures of those changes. So MS, I'm going to skip through some of this. It's a chronic inflammatory system. You guys are going to know most of this stuff. The slides are, if anyone wants my slides, send us an email. I'll give them to you. But MS is a relapsing remitting phase, then it turns into a secondary progressive phase, typically around postmenopause. And the transition from relapsing remitting to secondary progressives is quite reproducible. So the first thing I talk about people is the neuropathology. So when you talk about MS, people think, oh, okay, it's a lesion of the brain, white matter lesions, and this is what it looks like, right? So the slide on the figure on the left is one of the early scans of a white matter hyperintensity, and then a relapse later on shows additional scans. So a lot of times MS is a clinically isolated syndrome until we see recurrence. But the issue with MS is the inflammatory component of it. It's been studied very extensively. So we get these lesions in which the slide on the left is staining for the oligodendrocytes, which is the dark stain on the outside. So the white in the middle means there's a loss of oligodendrocytes. These are the cells that make the myelin, which is the white matter. The slide on the right is stained for the macrophages, or the immune cells. And the point is, if you look at the outer edge of that lesion, you'll see that the concentration of the macrophages are on the outer side. So it burns outwards. So it's the inflammatory component that actually causes the lesions to grow. And eventually it burns out. And this is an excitotoxic mechanism, which is also associated with ALS. And the key thing about MS is that if you take a look at the demyelination followed by the remyelination process. So this series of slides here, these figures show the areas that are in the process of being remyelinated. And the key point here is that the remyelination process occurs once the macrophages leave the area. So you can't have the remyelination occur while the inflammatory signals are present. And this is the other part about MS is that we focus on the demyelination process, but the whole word relapsing and remitting means that when they're in the remitting phase, that person is actually remyelinating. And actually the oligodendrocyte in the remyelination process is a very active, normal regenerative process in the human brain, run by these oligodendrocytes. And so this is what this myelin looks like. It's like basically taking a roll of electrician's tape and wrapping it around a copper wire. And the goal is to get a thick wrapping and a tight wrapping. So the point here is that relapsing is the demyelination phase, remitting is the remyelination phase. So clearly, the human brain has this ability to build itself up. Now, we focus a lot on white matter because that's what shows up on our MRI scans. But really, the functional deficit in MS is all related to the gray matter. So it's when the white matter degenerates to a point that it actually affects the nerve transmission that the white matter is protecting. So when that coating of the axon actually gets damaged enough that the signal transduction through those axons are impaired. And that's why when you're actually looking at the microglia, the inflammatory component of gray matter in multiple sclerosis, that you'll see the markers of microglial inflammation, not just in the white matter, and in fact, the microglial inflammation in the lesion area is actually lower than other parts of the brain because it's already, like Dr. Jordan will say, it's a terminal tombstone lesion. Nothing's really happening there. And so these studies show this very clearly that this inflammatory component of gray matter pathology is quite reproducible across the whole brain. And if we look at these microglia nodules in multiple sclerosis, that they're associated with the more severe MS pathology. And so I won't go through this in great detail here because I want to get into actual patient data, is that these microglia nodules versus something like stroke are very different. So in MS, these nodules are really contributing to the accelerated phase of multiple sclerosis. And then this normal appearing white matter has these oxidized phospholipids. So we talk about plasmalogens, restoring the myelin sheath. The myelination of the brain really starts early in development. So when we're first born, we're born very myelin deficient. And this myelination occurs, a key molecule is called plasmalogens, which are part of breast milk, and the child eventually reaches a point where they can build that myelination. But your brain goes from less than 5% myelination at birth to 60% of your brain is white matter by the time you get to an adult. And all that period most of that is occurring in the first 6 years of life. This oxidation of these membranes is what triggers the microglial inflammation. And if you look at these studies where they look at the inflammatory, where they can actually measure markers of neuronal axons and the markers of the inflammation, you'll see very clearly, we'll quickly go forward on this thing, is that the picture that you're seeing here is that you can see these axon tracks, and where the green disappears in the fourth slide is actually related to where the microglia are activating. So it's actually eating up the myelination. And one of my favorite papers that I spend all the time talking about is here. These microglia, and Dr. Jordan has a wonderful video if he has it. They're nasty. They're basically these little cells that saying they're just asking to be pissed off. It's like get off my lawn type cells. They're saying, okay, they're looking for cells that are damaged so that they can attack them, kill them, and go forward. But how does the microglia work? So basically the system of microglia is that the microglia themselves create an excitotoxic process with glutamate. And it's been studied. You get oligodendrocytes. If you hit lipopolysaccharide, which is a pro-inflammatory mediator, very little glutamate. But you put the microglia in place, and all of a sudden glutamate shoots up. And you'll notice, quite frankly, the very last bar there where the microglia is quite high, it shows you that the actual oligodendrocytes suck up the glutamate. And what glutamate toxicity does is it depletes glutathione, okay, among many, many other things. But glutamate itself is a mitochondrial stressor. It's a core component of inflammation. So whenever you have inflammation anywhere in the body, glutamate is a glycemic molecule. Every molecule of glutamate that goes into your cell, it sucks up a molecule of glucose at the same time. So it actually creates a stress, and what microglia do, it's a demand of service breakdown of a cell. It's going to say, I'm going to just bombard you with glutamate, and an unhealthy cell will eventually die because of glutamate excitotoxicity. So glutamate excitotoxicity is the body's natural way of killing unhealthy cells. And so when you talk about this process of loss of glutathione, cellular integrity, all these things that happen when you get apoptosis, interesting thing about multiple sclerosis is one of the common markers of MS is reduced glutathione levels because of this chronic inflammatory stress syndrome that they have. And we'll remember this slide because I'm going to show you what happens in Lisa's brain with glutathione if you actually treat it properly. So I'm going to skip ahead now. These are oxidative markers, axonal loss. We can measure peroxisomes in the animals. If you deplete the peroxisomes, which make the plasmalogens, they also make catalase and other antioxidant systems. You can create MS by just doing that. And these peroxisomes are actually reduced in the gray matter of people with MS. So I'm going to go through all this stuff. We studied this stuff, published this work, how it correlates with the rate of progression or the length of time someone's had MS and so on. And the neuropathology of gray matter, I'm also going to go through this fairly quickly. It correlates much better. So gray matter markers correlate much better with disability in MS than the white matter. And it makes sense because the gray matter is the functional part of the brain. So these just basically show the correlations between the gray matter changes and white matter changes. We use a molecule called cuprizone as a classic demyelinating agent. And what cuprizone does is it actually causes microgliosis. The first thing it does is it causes microglial activation. The second phase is astrogliosis. So microgliosis actually always precedes astrogliosis in the brain. And what happens is you get demyelination, very, very reproducible. And very reproducibly increase microglial activation. So what cuprizone does is copper chelating, it basically induces a microglial insult in the brain, and that microglial insult creates demyelination. So we've studied this quite extensively in animals, where we can demyelinate the animals, measure the plasmalogen levels, we can look at the myelination process, we can add plasmalogen precursors, which is the most critical component of the myelin sheath. And these are what these plasmalogen precursors do. There's an omega-9 that deals with the myelination, omega-3 I'll talk about for neurogenesis. But when you do this, you completely restore and maintain, in the presence of cuprizone, even though the inflammation trigger is there, these animals don't demyelinate. In fact, they actually have better myelination than the animals that are not even taking the plasmalogen, that they're not even taking the cuprizone. And you get complete restoration, cellular restoration. It's basically like the animals were not treated with cuprizone at all. You couldn't even tell if they were taking it. And this will happen not only before the cuprizone therapy, but it'll actually happen during cuprizone therapy. So after 4 weeks of continual cuprizone therapy, if we just put the plasmalogens in during therapy, the animals will remyelinate all the lost myelination that they had for the first 5 weeks of cuprizone. So plasmalogens in multiple sclerosis is a pretty big deal. But I want to get into a deep dive into Lisa's MRI results. So we're talking about a 53-year-old healthy person, 30 years of MS, 30 years of blindness. Baseline MRI, this is using Dr. Jordan's advanced MRI suite in Santa Monica. In March, did a follow-up in November. Very simple, we did mitochondrial support, N-acetylcysteine, acetyl-L-carnitine, bis-dimethoxycurcumin, CoQ10, 2 different types of plasmalogen restoration molecules that we've studied pretty extensively. And so what she immediately, she gets an improvement in vision, improvement of energy, has very less fatigue, and she has an improvement in mobility. Well, we want to see what's going on. So clearly the clear MRI lesions, like, yes, shocker, she has MS. So the lesions are there, they haven't changed in 6 months. The first thing we want to look at is the magnetic resonance spectroscopy, like Dr. Jordan was saying, where we can take a look at the metabolites of the brain. And what we noticed quite quickly is that, actually I'm going to throw my long-term glasses on because I can't read all these myself. This aspartate, which is also an excitatory amino acid, goes down quite dramatically from 10 to 4.5 in her brain. The creatine, which is a critical short-term energy molecule in these animals, in the brain, goes up. Her GABA, which is the suppressive, calming, inhibitory neurotransmitter, goes up dramatically. Glucose goes down, so she's no longer in that state. Glutathione, though, doubles. It goes from 0.7 to 1.4. This is in the brain now. Okay, so significant increase in glutathione. Inositol, which is a marker of inflammation, goes down quite dramatically. Lactic acid, which is a marker of mitochondrial insufficiency because you're getting anaerobic conversion of pyruvate to lactate, goes down quite dramatically. And N-aspartyl acetate, which is a biomarker, N-acetyl aspartate is a critical marker, studied pretty extensively in this, in terms of lipid biosynthesis and neurogenesis. So it's MRS. So reduced inflammation, increased antioxidant capacity, increased neuron biomarkers in her gray matter. That was in the precuneus. So let's look at cortical thickness. And so I haven't had time to talk, but we do a lot of work in ALS, and we have a very highly reproducible restorative program in ALS. We're basically batting 100% in ALS at this point in time. But a common component of ALS is a thinning of the motor cortex region. So this is Lisa's cortical thickness after 6 months on the protocol. And then we're looking at the motor cortex, dramatic improvement in the thickness of her motor cortex, and the occipital cortex as well. And if we look at the actual cortical thickness, you can see these regions. On the left, of course, is baseline. On the right is the follow-up. And you can see the cortical thickness quite dramatically improved. And also, cortical thickness in her occipital lobes are also improving. So clearly observable restoration of the cortical thickness in the motor cortex and the occipital cortex. Now, volumetrics, of course, is a tombstone marker from a epidemiological perspective, but if we're restoring function, the human brain, when it is activated, it grows. And so in terms of the visual pathway, obviously the right eye goes to the left occipital cortex, goes to the optic chiasm, and so on. But also the central vision is in the occipital pole. I don't have time to go through this thing, but it's not just that the occipital cortex gets activated, it then is going to have connectivity. It's going to be sending activity because the interpretation of the visual signal, is this a cat? Is this a dog? Okay, the interpretation of the visual signal has to actually occur somewhere else. So the occipital cortex will connect other ways. And so we can track this down and using either cerebral blood flow, but the big thing we talked about neurovascular coupling in these regions. In the calcarine area, we got increased neurovascular coupling by 40%, and actually the gray matter increases in both the left and the right went up quite dramatically. This is in the cuneal, the lingual. The cuneal and the lingual are afferent, they receive inputs from the occipital cortex. And if you look at the occipital pole, we're dealing with very significant changes. And you can see the 142% of normal. This isn't, a little over 6 months. So these changes in volumetrics are correlating with what she's observing in her life. And if we look at tractography, we can look at the full tractography of her brain. The motor cortex, of course, there's an afferent pathway and the efferent pathway, but it goes through the brainstem. So if we look at brainstem connectivity in baseline versus follow-up, you can see a tremendous increase in the fiber tracts being formed going from the motor cortex to the brainstem. And if you go forward to the thalamus, which actually controls your movement, so all movement gets ultimately directed through your thalamus, again, we're seeing this improved connectivity because these areas of our brain are waking up. And the connectivity of the left inferior occipital cortex, occipital gyrus, from follow-up through the corpus callosum, you can see our, well, not corpus callosum, but the connectivity is coming up pretty dramatically. And same thing with the middle frontal gyrus. So the question is, how is it possible to get regenesis of vision after 25 years of blindness? Like, what's going on here? And we're not talking about just protecting the brain now. So the plasmalogens and neurogenesis, if you take a look at Alzheimer's patients and you look at amyloid precursor protein, the amyloid precursor protein is critical because you can't design an animal without it. It drives our neurogenesis, and it drives neurogenesis through the alpha secretase pathway. And alpha secretase creates a peptide called secretory APP alpha. And you'll notice that the omega-3 plasmalogen, which is the DHA plasmalogen, not only is it improving synaptic function, but it actually specifically stimulates a peptide called soluble APP alpha. And this is actually a very, very potent molecule. And so it's used to rescue memory under conditions of impairment. It restores, it's neurotropic, neuroprotective, neurogenic, and synaptogenic. So this is why we're actually not just restoring the myelination, but we're seeing restored function because the brain is actually finding itself and it's regrowing itself. So in summary, MS is a chronic inflammatory condition of the CNS, resulting in widespread demyelination, axonal and synaptic gray matter. Chronic microglial activation is a key driver of this, and it creates a metabolic load, both on the support cells, the oligodendrocytes, and the neurons. That's beyond the endogenous capacity of the individual to resolve. And most likely due to genetic weakness in mitochondria, because MS is fundamentally a mitochondrial disease or a risk factor. So reinforcing the mitochondrial peroxisomal membrane function enables the person's endogenous system to resolve current and prevent future inflammation. So that's it. Thank you very much for your time.